Well, I want to thank you guys for having me back. I've been at UCSD for about 7 years now, and this is one of the first community talks that I've given since I joined UCSD 7 years ago. And since then, I've been doing a lot of these outreach events, speaking to cancer survivors, and you guys are still the most informed group. I remember I got a lot of tough questions on my first talk 7 years ago, but I expect more today. So feel free to stop me at any time. And this is not meant to be me reading slides to you guys, so we can talk. This is meant to be a conversation. And as they mentioned, I'm now we just opened our men's health center. It's down the street from here. So that's where we see most of our patients, both cancer survivors and non-cancer survivors. So, and there will be some information if you guys have questions. Sometimes it's a little bit embarrassing this is very personal, so if you have questions, I'm happy to stay after the talk to talk to you one-on-one as well. So as many of you know, there's goals of cancer treatment, and that these are some of the stuff that as your doctor we think about when we're prescribing treatment or thinking about treatment for cancer patients. Obviously, safety. We don't want to make you worse off than what you started with, so safety is very important. And then the next thing is cancer control. You know, the goal is to get rid of the cancer, whether it's through radiation, whether it's through surgery, through chemo. The goal is to get rid of the cancer safely. And we also want to minimize side effects. And as we advance in our treatment for cancer, people are living longer, like many of you who's been diagnosed 20-some years ago. So back in the day, we used to say, well, you know, you're lucky that you're still alive. But today, our priority has changed. People's quality of life is really a consideration for everybody. So just because we can keep you alive, but if you're worse off than what you started with, I'm not sure many of you will choose the same treatment. And a lot of times people see me, they would tell me things like, you know, if I knew this is what it was going to be like, I probably wouldn't even want to have it treated. So that's something now that we're having more discussion with patients and helping you all choose what the right thing is. But specifically with prostate cancer, you probably heard of everybody want to brag about their rate of trifecta. What are the trifecta? Number one is cancer control, whether it's surgery, radiation, chemo. The second thing is we want to make sure you're not wearing a diaper for the rest of your life. We want to preserve your urinary continence. And the third part is preserving your sexual function. And this is the priority every prostate cancer doctor are trying to do for you. And we're not going to compromise one for the other. And when all three things are achieved, we call it the trifecta. And that's what doctors brag about at our meetings and say, you know, what's your percentage of rates you can help people to achieve all these things. But what are some of the sexual side effects of cancer treatment? ED. You know, even if you don't have cancer treatment, as we get older, we need help with our erections. So, but definitely after cancer treatment, whether you choose surgery, whether you choose radiation, whether you choose hormone or chemo, there are sexual side effects. Bless you. And second thing is ejaculation problems. As many of you know, once you have treatment on the prostate, it can affect your ejaculation, not just your erection. Not uncommon, people start getting scar tissue buildup, and then they complain that, you know, I'm not as big as I'm 18 years old anymore, or they start having curvatures and deformities. And people can also have issues with orgasmic function. Some people don't leak normally, except when they're trying to have sex, and that's called climacturia, and that's one of those things that it's very, very common, actually. And the last thing is that people can have hormonal imbalance or decreased sexual desire or libido, and that's more common in people who receive androgen deprivation therapy, where we chemically castrate you with medications. But a lot of guys, even we take you off the medicine, your hormones do not bounce back. So we give you an expected period of time for your hormone to come back. But if it doesn't come back, part of my job is to help you restore the hormonal balance that we'll go over a little bit later. So what is ED? This is what they teach us in medical school. Basically, it's the medical textbook says it's the inability to obtain or to achieve an erection sufficient for sexual activity. And there's multiple causes, but we now know that it's an important part of our quality of life. It's an important part of how we view ourselves as men. It's an important part for our relationship with our partner. So we don't ignore it anymore. So how common is it? As I mentioned, even if you did not have cancer, 1 in 5 guys in America have erection problems. That's over 30 million American men. Back in the day, we used to say that it's all in your mind. You know, if you have erection problems, go see a shrink, okay? But in today's world, we know that 90% of the time, there's a physical reason, and only 10% of the time is psychological, okay? It's not uncommon, people have both, okay? So what is supposed to happen? So this is kind of a picture of what your penis looks like internally. So when things are flaccid, things are just hanging out like it's supposed to be. During erection, the arteries in the middle brings the blood flow to the penis, and these space is called the corporal body, starting to swell. And once the blood fills these space, it becomes hard. And then for you to maintain erection, the veins on the side of the penis gets pinched off. That's how you maintain erection. And this is what is supposed to happen, okay? And after prostate cancer treatment, many of these mechanisms are affected. The blood flow is not as good. The venous drainage is not as good. Some people say, well, I can get an erection, but I can't maintain one. It's because the blood is still coming, but if you can't pinch up those veins, then your blood will leak out. It's like you're trying to fill a sink with the bottom of the sink open. No matter how much you turn up on the faucet, it's just not going to fill. And as you talk about the nerves, we talk about, do you preserve the nerves? Don't save my nerves. And nerves is also important to communicate with, to maintain normal blood flows. So guys can have blood flow problem from the artery and the vein, and also a neurological problem. And this is why after prostate cancer treatment, our erection is never as good as what we started. So what are some of the other things? It's not uncommon. We have more than one problems. As we get older, our rate of other medical problems goes up too, such as diabetes, heart disease, certain medications that you might take for your blood pressure, and sometimes people can have injury to their back, whether it's in wheelchairs or you're just having disc problems, and those nerves can also affect your sexual function. And lastly, hormonal balance. In cancer treatment, it's not just prostate cancer. I see all cancer survivors for UCSD, not just for prostate cancer. And then a lot of these other cancer survivors share the same side effects that you have, such as bladder cancer, colon cancer, rectal cancer. And we know that more than half of the guys will need help in their bedroom, okay? So you're not alone. Some of the other things, it's not uncommon. After you get diagnosed with cancer or been treated with cancer, you can still have a little bit of depressed mood, and that can certainly affect your sexual function. It's not uncommon that we usually lose weight after you have cancer treatment, but it's really easy to gain your weight back. So I would see a guy maybe 3 months after surgery, and they're recovering, they lost about 20, 40 pounds. When I see them at a year afterwards, they gain it all back and then some. So there's other healthy lifestyle stuff that can also affect your sexual function. Drinking, some people do recreational drugs, and smoking. So what do we do? So we're going to talk about testosterone. We're going to talk about the pills. We're going to talk about the urethral suppository or muse. We're going to talk about vacuum. We're going to talk about injections. And we're also going to talk about penile prosthesis. I tell every man who comes to my office, I can give you all an erection, just how far we have to go, okay? So we start making these choices together and try to do the right thing for you. If you're a single guy versus you've been marrying for 30 years versus you just married with a 40-year-old wife, everybody's goals are different. So it's not a one-size-fits-all for anybody, and that's why we have a lot of options, and we try to figure out what makes sense for you and your partner, okay? So we're going to talk about testosterone. There are many testosterone options, and the pills is available, but it's only available in Europe. The reason is that when you take a testosterone pill, it gets metabolized in our liver, and people can have liver problems. So that's why oral testosterone is not available in the US. But in other countries, South America or Europe or in Asian countries, you can still see people taking oral testosterone pills, okay? So before we talk about the options, there was a lot of time people ask me, my doctors castrate me for prostate cancer, and now you're gonna talk about giving me testosterone? Wouldn't it be kind of like putting gasoline on fire? And that was a traditional belief, okay? Back in the day, we used to think giving testosterone to prostate cancer patients is like putting gasoline on fire, okay? But we now know that it's not healthy to live with the hormones in a toilet, okay? When we're starting to put men on hormonal treatments, yes, their cancer, we can control the cancer, but people were not living longer. They were dying. We're like, well, why were they dying? They don't have cancer anymore, because they're dying of other problems. When you have low testosterone in your body, especially at the castrated level, you start having bone health issues. It's like women going through menopause. You start talking about hot flashes and all the side effects that women go through. You start having cardiovascular problems. So a lot of people are dying of heart attacks and strokes and breaking their hips and having other complications. So that's why we start limiting the duration of we put people on hormones. So the longest you will get hormones, probably 2 years associated with radiation treatment, because we don't put people on lifelong hormones anymore. And we also feel that with more research that giving testosterone to prostate cancer patients is safe, okay? So we will not make your cancer worse. We will not make your cancer come back. We will not lead to metastatic disease and things like that. So, but it is a delicate situation. It's very individualized, and I write more testosterone prescription than any doctors in San Diego. And a lot of them are prostate cancer survivors. We do it for men on active surveillance. We do it for men on post-prostatectomy, radiation. So like I said, everybody is individualized. So we want to make sure balance your cancer control and make sure keeping your body healthy. But these are some of the options available. There's injections, there's topical gel and patches, there's even long-acting testosterone implants. So we usually make these decisions between you and your cancer doctors and myself, and we'll talk about figure out a regimen that's right for you and make sure that we're achieving the goals that you hope to achieve.
You said only 2 years, right?
The 2 years is for people that's on hormone deprivation therapy. Okay. So that's why we don't put your hormone in the castrated level for more than 2 years if we can help it. Because the longer you're on it, that's just not healthy for you. And that's why you want to hear about people calling about intermittent androgen deprivation therapy, where they put you on these shots and then they take it off and they put it back on again, so give your body a chance of time to recover. Unfortunately, if you've been on long-term hormone deprivation therapy, means that they castrate you chemically. Even when we take you off the Lupron, the Casodex, most of the guys' hormone will not bounce back to the level that before treatment, okay? So there is some long-term lingering effect of these medications. So we give you, in general, 6 months to a year for your body to bounce back from Lupron, from Casodex and these medications. But if at 1 year your hormone is still not where you're supposed to be, then it's unlikely for your body to make more testosterone on your own, and then we start talking about potential replacement options.
And this is the dosage normal for TRT. Any particular limit for prostate cancer survivors?
Great, that's a great question. The question's about the dosages. Is there special dosages for prostate cancer survivors versus regular guys? There isn't, okay? In my regular guys, I'm not trying to make them bodybuilders. I'm not trying to make you guys bodybuilders either, okay? So if you tell me that I want to look like Arnold or look like the people I see at bodybuilding competitions, unfortunately, no amount of testosterone will be able to get you there, okay? They're on different kind of steroids. But you're right, there is safety concerns. So we usually want to make sure your levels are middle of the road, not too high, not too low, okay? And then that's why we have a lot of options, and we'll try to individualize it for every single man to keep you at a safe level. Because there are additional side effects to testosterone replacement therapy. One of them is that it can cause what we call erythrocytosis, or too much red blood cell count, okay? If we overshoot your testosterone level, we're going to overshoot your red blood cell level too. Sometimes the cancer patients are anemic. So that's a good side effect to have because you need more red blood cells for you to function better. But if your blood counts are normal on the high side, if you have too much and we make a number go up more, your blood gets too thick, we do worry about blood clots. So every man on testosterone replacement treatment, with or without cancer, I monitor your blood count at least twice a year because there are other side effects that worries me. But to answer your questions, there's not a specific dosages that we put the cancer patients on.
And is this indefinite then?
Yes, so this is indefinite. As a man get older, our hormone level goes down, just like women going through menopause. So your body will not make more hormone in the long term. So if you need help with your hormones, this is no different than diabetics need insulin shot for life. This is no different than people with thyroid issue. They're taking Synthroids or thyroid hormones. This is a lifelong treatment. Yep.
Does the testosterone test have to be done fasting or at any time?
That's a good question. Testosterone test does not need to be done fasting. It is best to be checked in the morning. It's most accurate in the morning because there is certain circadian rhythm to the testosterone testing. So we usually tell the guys to go to the lab ideally before 10 a.m. Okay, unless you work night shifts where your sleep pattern is off, then we have you do your test based on the normal rhythm.
You were talking about the effect of hormone treatment, which can make it permanent. Okay, how long make it permanent?
Well, every man is different, but we know that at the minimum, most people receive androgen deprivation therapy, ADT or your Lupron and your Casodex. It's minimum of 6 months. Okay, so if you choose radiation treatment for your prostate cancer, your radiation doctor is going to put you on hormone deprivation because studies have shown that give you the best chance of curing you of cancer with radiation. So radiation usually are combined with androgen deprivation. So so minimum 6 months. But the longest in somebody with aggressive prostate cancer, they usually keep you on it for 2 years. Okay.
At what point does it affect?
When it becomes permanent?
Yeah.
Unfortunately, nobody really knows. It's really based on your own biology. Everybody, we are all born with a finite ability to make hormones, okay? And depending on what your starting point is, how much can you bounce back? It's different, probably based on your overall health and some genetics as well. So that's why we give every man a chance. We don't just say that you got Lupron and Casodex, you're gonna be on testosterone. We give your body a chance to bounce back. But after about 6 months to a year, when you're off these medications, if your body still has not recovered, then we start talking about helping you. So next thing we talk about are the pills. Viagra, these are medication that came out, decades ago now. I think what these medications have done well for us is that, not that it gives you all an option to treat your ED, is really that prior to these medications come out, you never see a commercial about ED. In today's world, I think you can go over the world. People heard of Viagra. So the marketing is great. But I think more importantly, they hopefully help all of you become more comfortable talking about your sexual health and ED. So this is not something that you have to be embarrassed to go see your doctor about. Now people are more openly discussing their health in the bedroom, and I think it's because of these medications, because we put these conversations, on a national stage during commercials, and people now are comfortable talking about it. But these medications still available today. Now there's generic options, which is the good news, because previously it's very, very expensive. Most insurance companies think about ED as a lifestyle problem. So it's not life or death. So even for cancer survivors, it's very hard to get these drugs covered. So I think that's one area that, as all of us, both the patients and the doctors, we need to do a better job advocating for ourselves and also for the disease. A woman with breast cancer, not only their cancer treatments cover, a lot of their reconstruction, their breast implants are all covered. But for men, unfortunately, even you have prostate cancer, we're still having a hard time helping you obtain the coverage that you need to help you recover from these treatments. So that's one of those things that we're always working every year. And now we have advocacy groups going to Washington, D.C., talking to senators and that kind of stuff, trying to raise awareness and importance. So hopefully all of you will get the same coverage that breast cancer patients will get. But the medications are available. Now there are, and they all work differently in different people. They all take a little bit of planning. It takes about an hour for it to work. So you got to take the pills at least an hour before any sexual activity. You got to watch what you eat. If you eat a big greasy meal or have a lot of alcohol, you would decrease the absorption. You just paid $20 for these pills. So let's make sure we take it properly and give it a chance to work. And unfortunately, they all have different, they only last an amount of time. So if something happened that night, your partner's not in the mood, unfortunately, you're out $20, okay? So it does take a lot of planning, okay? But if it works for you, it's one of the easiest way to help you restore your erection. There's just a pill, okay? There's even daily dosing. You might see treatment you can take on a daily basis instead of on demand. And we use this for rehabilitation protocols a lot because that helps maintain a certain amount of blood flow to hopefully help your body recover. And these are what's available. The pill is what we call first-line treatment, because if you haven't tried it, let's start with the easy stuff. But unfortunately, most of the guys have had cancer treatment. The pills will not be strong enough, okay? And even if it is, they say, well, the best case scenario, I get like a 50% of what I used to get. It's something, but it's really not enough for me or my partner. So that, and most people get their pills from their primary care doctor. So I rarely actually write prescriptions for pills. When people come see me, they already tried the pills and unfortunately it hasn't worked out properly. That's when we start talking about what we call second-line treatment or what else is available. There's a urethral suppository. Many of you who had surgery probably still remember having the catheter. The catheter is probably the worst experience of any man's life. Those 5, 7 days, 14 days, how many days you have the catheter is probably the most torturous week of your life. But the same place where the catheter go in and out, that's where you would put the suppository, okay? When we take a pill, the pill goes around our whole body. It takes about an hour to find our penis. And then when it gets to our penis, probably only about 5 or 10% of the active ingredient actually gets there. So now we start talking about how do you deliver 100% of the medicine to the area where we need help the most. Suppository is one way of doing it. So basically, it looks like this, and that there's a little pellet about the size of a tip of a ballpoint pen-ish, and you put it at the tip of your penis, and then you let it dissolve locally. So if it works, then it can get you an erection. But unfortunately, it was an option, but in today's world, it hasn't fallen out of favor for multiple reasons. One, it's not as effective. For it to work, you had to use a pretty high dosages of these suppositories, and it burns. So people tell me that, well, it worked. I'm like, great. But I feel like my urethra is burning. It's like I'm wearing a catheter the whole time. So there's no way I can be sexually active with my partner when I have that feeling of a burning urethra, like having a catheter, to do anything. So it's not very well tolerated, okay? And then it's also very, very expensive. So it's probably just as expensive, if not more, than the Viagra or the Cialis. So it can be also cost prohibitive. But in some people, like if you're a veteran, the VA still covers these medications. So it's not uncommon that some of our vets, want to try this because they don't want to talk about needles and syringes just yet. So we do give them a try. But it's still available in the market today, and we just don't use it as much for the reasons that I spoke about. How about a vacuum pump? Vacuum pump, it's one of those like old faithful things that it works. It's a mechanical device. Basically, the pump generates negative pressure, draws the blood into the penis, and that's how you get an erection. Unfortunately, for you to maintain an erection, there's a rubber band called a constriction ring that you have to put at the base of your penis. It has to be pretty tight to be able to maintain the erection. So, as you can imagine, it's starting to get very complicated. starting to get very uncomfortable. And people tell me that it's like you have a rubber band put around your finger, and after a while you start feeling numb, and it can cause some bruising. So in today's world, we use the vacuum more as a rehabilitation tool, less for sexual activity. But we still use it because in the beginning, when you're recovering from your cancer treatment, you might not be in the mood. You might not say, well, I'm not 100% yet. My sex drive is not there, and I'm still trying to figure out the changes. So we tell them that, well, this is not for sex anyways. Why don't you get a vacuum pump? Instead of we talk about putting needles and pills, just get a pump and use it as a stretching exercise. Because as I mentioned before, after cancer treatment, there can be scar tissue built up internally. But even without cancer treatment, penis is one of those organs that it really follows the phrase, if you don't use it, then you'll lose it. Okay, so if you haven't had a normal erection for 6 months or a year, there'll be some changes. So an erection device keep your body stretching. That's why when we were younger, we wake up with morning erections. That's our body's own natural way of stretching, okay? But unfortunately, after prostate cancer treatment, most men are not waking up with morning erections anymore. So this is a way for you to stretch yourself. And studies have shown that it can improve oxygen delivery, which is important for healing. It can also preserve the size of the penis, so which as all of us know, that nobody has extra room to lose. And you can use it pretty early on. Once the catheter comes out, you can start using the vacuum. Okay, so it's not something you have to wait till something heals and that kind of stuff. You can start using it right away. And in some people, surgery is not an option, and that they fail everything else. Vacuum pumps, mechanical device, it works in almost all the men. Even if you have nerve damage, yeah. For most of the guys, injection is what they try after they fail the medication. And this is probably the joke that I told 7 years ago. When I tell people about injections, they look at me. First, they don't think I'm old enough to be their doctor. And secondly, they definitely don't think that I know anything about ED. What do you know about ED? You look like you're 21. And then third thing, there's no way I'm putting a needle in my penis. You're crazy. So this is what conversation I get to have every day. Okay, but yes, it is crazy. I am asking you to put a needle in your penis. Okay, it's really no different than diabetics give themselves an insulin shot. Okay, it's a needle. It's a needle. It's the same type of needle. It's a couple of drops of medications, but you're right, it is different because it's going to the very sensitive part of our body. It's not just in our belly fat area. But it works, okay, in the guys who can handle it. It works in 90% of the guys. So I'm not worried about it not working. I'm worried about it working too well. Because if we're not careful, you give yourself one drop too many, you can have an erection lasting longer than 4 hours, called priapism. We hear about that on the commercials. For most of the guys in this room think that's a good problem to have because you're having a hard time with erection to start with. You say 4 hours sounds pretty good. But unfortunately, it's not, okay? It's an embarrassing trip to the emergency room. What happens when you have an erection for more than 4 hours is that the blood flow that's there starting to clot. The blood doesn't drain, and it becomes painful. And then if you think the needle to inject to get you an erection is big, when you go to the emergency room, either me or one of my residents or an ER doctor will put a needle about 10 times the size to drain the blood, okay? So that's why we have to be very, very careful when we use these medications. And we usually do the first injection in my office because I usually assume most men have never put a needle in their penis before. So there's some teaching involved. So we try to do it properly, so hopefully we'll minimize your pain and suffering. But most importantly, I want to make sure you don't have an overdose reaction. So we try to figure out the right dosages for you before we cut you loose and let you do it on your own. The ideal response with the injection is that a man give himself a small injection. They start the foreplay process. Within about 5 or 10 minutes, he should generate an erection. So this is not like the pill, you have to wait an hour. An erection should not last longer than 1 hour. And after he climaxes, the erection goes away. that's the right sequence of things. And we help you figure out what that dose is, and we especially want to minimize the side effects. In people who are afraid of needles and syringes, there's a thing called auto-injector, where you just put everything in the, draw out the medication, all that kind of stuff, and you push a button, and then the contraption give you the shot, so you don't even see the needle going in or anything like that. So there are things that we do, and what's the medicine are different vasodilators, and these are some of the formulations available that you might hear about it or doctor might talk to you about. But it works in most of the guys as long as you can talk. You don't faint. We have guys who cannot give themselves injections, but their spouse or partner are nurses or other people that are very motivated. So they say, no problem, I'll do it for him, so that both husband and wife will come, and then we would show both of them, and then it's not uncommon. The spouse or the partner is the one that gives the shots, and actually not the men themselves, because we know that, women are tougher than us. So how satisfied our people are with all these things? In general, 40%, it's hard to see. The first one is talking about satisfaction for injections. For injections, about 40% of the guys are happy. Because in general, even though it works, it's a needle, in your penis. So not everybody want that, and I understand. The pills, about half the guys are satisfied. Usually people are not happy because of ineffectiveness, because of cost reasons, and sometimes there's a lot of planning involved that they're not happy. But when people try these things, they end up having surgery. 90% guys are satisfied. But this is probably a little bit of a selection bias, because these people usually have tried the other treatments already. So, and a lot of times they fail the other treatments already. So the surgery obviously is something that's effective, so they're happy. Even though the most recent guidelines talk about we don't have to go through all the steps that I talked about to have surgery, in today's world, we still have you try the non-surgical options first. Because obviously, if we can help you without surgery, that's the best. But if you do need help with surgery, we're also here to help you too. I think that's the difference between what we do and versus some other doctors, is that we're able to offer you everything from A through Z. We can help you from the easiest form to the most difficult form, okay? One of the things people are always very intimidated with surgery is that if I can't even afford the pills, how can I afford surgery, But in some crazy world that we live in, even though the insurance companies do not cover Viagra or Cialis, they will not cover the suppository, they will not cover the vacuum pump, they will not cover the injection shots, but they will cover surgery, okay? So you don't have to worry about cost when you're thinking about surgery. So what is surgery? Basically, and that's what I do, I do about 2 or 3 surgeries per week, 50 weeks a year, and so we do a lot. Surgery is basically, instead of your body generate an erection, I do it for you with an implant. And this is what it looks like. Essentially, it's called multi-component or inflatable 3-piece prosthesis. So it's a hydraulic system for the engineers in the room. People want to know how it works. There's fluids that travels, and that's what fills the implant. Essentially, there's water balloons. I put 2 water balloons inside your penis, and it's controlled with a pump. Okay, everything is hidden inside your body. And the fluids normally are kept in what we call a reservoir or another water balloon. Okay. Normally, since 90% of the time a man spend with their penis flaccid, the water balloons are empty. Okay, so it feels natural, it feels normal, just like how you feel now. When you want to have intercourse, you pump the fluid from the reservoir into the fluid and then come out. And it fills the implant with sterile saline. Once it's full, you have intercourse. You have intercourse for as long as you want. Even after you climax, the implant is still up because the water balloon is still full. When you're done with sexual activity, there's a release valve. There's a button that drains the fluid back into the water balloon. Okay, so this is how the mechanics of it work. It takes about an hour, and you spend one night in the hospital. So this is kind of like where the implant sits. You can see the two long cylinder type water balloons in the penis. There's a pump in the scrotum next to the testicle, and there's water balloon in your belly. So it goes soft normally, and when you want to have intercourse, you would pump it up. And this is what it looks like. At rest, it's soft and with an erection. Okay? So for the most part, I don't offer surgery to people who at least, I make them try injections and I make them try the pills. You have to at least give it a try. You don't have to try it for a long time, okay? But just give it a try and don't just poo-poo it or whatever, you know. But if you tried it and that's not satisfactory to you, or you can tolerate it, or you're not getting the right response, then we talk about surgery. We've been doing this for 30 years. This was actually invented at Baylor, where I did my training 30 years ago. And there's been multiple modifications now. Now this is fancy silicone. Now the implants are coated with antibiotics to decrease infection. And for the most part, it works. And the lifespan of it is about 12 to 15 years. So I tell the guys I see today that 12, 15 years from now, this is going to stop working. You're like, why? Because it's a hydraulic system. Well, usually the reason for mechanical failure is that the fluids leak out. So what happens is they will pump and nothing's going to happen because there's no more fluids. It's saline, so it's safe for your body, so you will not get sick. This is not like silicone breast implant that people can get sick from it. But unfortunately, without the fluids in there, the hydraulics doesn't work. So if 12 years from now, you tell me that, you know, that part of my life with my partner is over, it doesn't matter to us anymore, we don't have to do anything. You can actually live with an implant inside your body. You can take it to the grave with you. You don't need to have it removed. But if 12 years from now, you tell me that, you know, I don't know why my wife still want to be with me, and then I got to keep her happy, so you will need, and how do I make this work again? Can you just add fluids in there? The answer is no, okay? We do have to do a replacement surgery, so we'll take out the old implant and put a new one in. But for the most part, it should last you 10 or 15 years. The person that I have seen with the longest implants about 18 years, and then it's still working. But there is a definite lifespan of the implant. So that's what's available for erectile dysfunction. So these are some of the athletes you might or might not recognize. So all these athletes have surgery, and then to get them back to their normal shape, they undergo rehabilitation. So the last part of my talk, we're going to talk about rehabilitation. Back in the day, we used to say, you know, Mr. Jones, you survived surgery. It's going to take a year or a year and a half for your body to heal. Go home. I'll see you about a year and a half later. Whatever your body cannot heal, we see you back, and then we can help you. We now know that's probably the wrong approach. You are not any different than these professional athletes. The only way to get your body back to your pre-treatment shape is to rehabilitation, okay? So now, then this is not a new concept anymore. 7 years ago when I came here for the first time, most people have never heard of this, and most doctors did not offer this to them. But in 2019, if a cancer doctor did not discuss rehabilitation with you, that's actually kind of an outdated way of taking care of all the cancer survivors. So now what I do as part of the cancer survivorship program at UCSD is that we rehab you. You know, we treat you like Tiger Woods, like any professional athletes. We're going to try to help you. So hopefully when the healing process is done, you are as close to your shape you were before surgery or radiation. So what's the goal? The goal is to preserve the tissue, which is the smooth muscle inside your penis. We also want to preserve endothelial function, which is the blood flow, okay? And then we also want to optimize the nerve recovery, even if the doctors say that they save your nerves, which you will hear a lot. We say, were you able to save my nerve? The answer is yes. But by saving your nerve doesn't mean there's no injury to the nerve, okay? That just means that they did not cut it, they did not take it out with your prostate, but there's still surgery. There could be cautery artifact from thermal injury to the nerve. It could be stretch injury to the nerve. So there's some healing for the nerve as well, okay? And so things we do, we use medication, all the things that we talked about, you know, the medications, the injections, the suppository if you need it, the vacuum pump, and if you need hormone replacement, because your hormone never bounced back from your Lupron shots or your Casodex, we also give you help, okay? So before surgery or before radiation, we try to put you on a low dose oral medication to start improving circulation. And this can be Viagra, this could be Cialis, anything. We basically try to find the best cost-effective option for you with minimal side effects, because we want to keep your blood flow going. Because you're going to be like, I'm not in the mood, you know, why are we trying to talk about sex or anything, you know, I have cancer and I'm not ready. But this will help you in terms of keeping the blood flow going. And then hopefully we can get you a morning erection once in a while with these medications. And then once you're about a month after you're done with surgery or radiation, we start talking about the vacuum pumps or higher dosages of the pills or even suppository if that's tolerated. If you're not getting normal erection 3 months after treatment, we start talking about injections. Because like I said, this is one of those things, if you don't use it, you'll lose it. So we want you to start getting erections as early as possible, even if you tell me that I'm not in the mood, because that's what's going to give you the best chance of healing. And studies have shown that early, even if it's medically induced erection, leads to better outcomes at 16, 18 months after treatment. So that's why it's important to get this started early. And then at about 6 months after treatment, we start checking your testosterone level. We want to make sure you're cancer-free, your PSA is stable. And this is no different than active surveillance patients. You know, if your PSA is stable, we now do MRIs, we do various things to make sure that there's no changes to your cancer. Then we think it's safe to give you testosterone at approximately 6 months after your diagnosis. And at about a year, at 1 year, 90% of the healing is done, okay? So it's very rare people say, I have nothing at 1 year, and a year and a half, I'm back to normal, okay? So this is a process that improves with time, you know? So usually at 1 year, if you're still not getting the sexual function that you hope to be, we start talking about surgery. But I usually give you at least 16 months, a year, and about 4 months or so, a best chance of recovery on your own before we actually do your surgery. So, so that's kind of what the timeline might look like, and this can be replaced with radiation. This can be replaced with chemotherapy. The timeline doesn't change. It's just that, you know, everybody needs different amount of help at different stages. But there are various milestones that I expect you guys to hit, you know, during your recovery. So if you're not there, that's when we adjust the treatments for you. But that's kind of how, that's why I see the guys, you know, 1 month after treatment, 3 months, 6 months, at about 1 year. So that's what it's like. So this is my last slide, and then we can answer as many questions you want. So I want you to know that sexual problems is normal to all cancer survivors. It's not just unique to prostate cancer. We have a lot of treatment options we can help you. And rehabilitation in 2019 is really a very critical part of how we take care of cancer patients, and that we give every man a chance, and your best chance is to rehabilitation. Any questions?
Okay, thank you.